Good afternoon, everyone. Welcome. I would like to remind you that this conference is being recorded. At the moment, all participants are in listen-only mode. For those that are connected by telephone and require operator assistance during the call, please press *0. For those online that require assistance, please use the chat box on your screen. I would like to hand the meeting over to your host, Tanya McDonald, Program Director at CFHI. Go ahead. Thank you very much, and welcome. Welcome to this 7th installment in our series, Next Steps for COVID-19 Response in Long-Term Care and Retirement Homes. Today's webinar will focus on the vaccine rollout throughout Canada in long-term care. I'm Tanya McDonald, and I'm a Program Director here at the Canadian Foundation for Healthcare Improvement. I'm hosting this webinar from my office in Ottawa, and I acknowledge that Ottawa is located on the unceded territory of the Algonquin-Anishinaabe Nation. We are pleased to offer this series of webinars in both English and French. So for those of you that would like to listen to the French audio, please dial the phone number on the screen, and we'd also ask you to write your questions and comments in the chat box in either French or English. As a reminder, the LTC program is based on findings described in the report entitled Reimagining Care for Older Adults, Next Steps in COVID-19 Response in Long-Term Care and Retirement Homes, which was released last July by the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute. The report is based on more than 40 interviews with family partners in care, healthcare leaders, and policymakers. It focuses on promising practices in 6 key areas that have the potential to reduce the risk of future COVID-19 outbreaks or mitigate their effects. Preparation, prevention, people in the workforce, pandemic response, and surge capacity, as well as planning for COVID-19 and non-COVID-19 care and family presence are the main thrust of this report. So for this program, the Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute partnered with a number of organizations across Canada, and we thank them for providing their support since last July. Today's objectives are really to learn from several long-term care homes across the country on their vaccine rollout strategies, to offer COVID-19 vaccine preparedness resources for long-term care and retirement homes, and as well to share LTC Plus, Acting on Pandemic Learning Together program updates and next steps. So today, I'm pleased to introduce you to our speakers. Jacques Ricard will be your host today. Dr. Ricard is a graduate of the Faculty of Medicine at the Université de Montréal. He's devoted his professional practice to family medicine, more specifically obstetrics and newborn care. After earning a master's degree in health services administration from the same university, he served as Director of Professional and Hospital Services in Quebec institutions and medical advisor to the Health and Social Services Ministry in Quebec. He was a surveyor for the Canadian Council on Health Services Accreditation for 5 years, and he's also an extra fellow here at CFHI. He was the provincial coordinator for Opus AP during phases 1 and 2. Lucie Tremblay is the Director of Nursing at the CIUS Centre-Ouest de l'Île de Montréal. She is a graduate in nursing with a Bachelor of Science and a master's degree in Health Services Administration from the Université de Montréal, with more than 35 years experience in nursing in Quebec, including 33 years As a proven leader, Lucie Tremblay knows how to successfully lead an organization. She has worked for nearly 28 years with a geriatric clientele, and for 6 years, she was president of the Ordre des Infirmières et Infirmiers du Québec. And during this period, she notably contributed to enabling nursing prescribing, creating new specialties for specialized nurse practitioners, and assumed strong leadership in interprofessional collaboration. Throughout her career, she sat on various committees to promote the development of care and services. And she's taught and participated in major research projects and has been a guest speaker at countless conferences. Marie Boutette is the Chief Operating Officer at the Pearly and Rideau Veterans Health Center, a senior care organization that holds 450 long-term care beds and 139 seniors apartments, as well as a wide range of services covering the entire continuum of care. The facility specializes in care and services for veterans, and is found in Ottawa, Ontario. Over the past 20 years, she's held many leadership positions in the healthcare sector, and her areas of expertise are strategy development and implementation, operational excellence, and quality improvement. Marie Boutette holds a master's degree in health administration from the University of Ottawa and a Bachelor of Science, Life Sciences, from Queen's University. She is a lean green belt and was part of the first cohort of the Ideas Advanced Training Program in Quality Improvement offered by the Ministry of Health and Long-Term Care in Ontario. She lives in Ottawa with her husband, Jason, and her daughters, Claire and Catherine. And finally, Erin Baudouin is the Chief Motivator and CEO at Eden's Gardens, a long-term care facility in Nanaimo, British Columbia. It's designed to accommodate 130 seniors with dementia, and it employs over 240 people from 2 trade unions. She sees herself as a leader in serving others and believes it is essential to provide employees with the support they need to optimally look after the well-being of our seniors. And now I will hand the microphone over to Dr. Ricard, who will moderate this as a roundtable. Over to you. Thank you very much, Tanya. Welcome, everyone, to this webinar. So today we'll be looking at 5 themes. Quickly, vaccine strategy, so those people that are targeted by vaccines, how this was rolled out in your pilot project, especially with the Pfizer vaccine. So how did you certify individuals to provide the vaccine? Who was in charge? So what leadership was deployed to ensure the vaccine's rollout? And there's a few institutions, including Ms. Tremblay, who have carried out a survey, and it'll be interesting to see with her what the results of these surveys are. We'll see if others, in fact, have done surveys. And another thing, managing refusals. This is something that we have to deal with. When somebody refuses the vaccine, what do you do? So I'll start with the person who's the furthest. I'll start with Eden Gardens. So Erin, perhaps you could tell us what your strategy's been, your residents, staff, physicians, and essential caregivers. Over to you.
Sure, thank you. We vaccinated everybody with 2 different vaccines. Our staff received the Pfizer vaccine, and we all went to a clinic and were vaccinated at a public health clinic through our health authority. And our residents were vaccinated with Moderna, and they had our health authority sent public health nurses to our home. And they rolled through each neighborhood in it probably took about 5 or 6 hours to get through the 130 residents. Because of the delay in distribution from the federal government, we've moved our second doses a number of times, so none of us have received our second doses yet, and we are earmarked to get them at that 42-day mark. That's been confirmed for staff, and we're waiting to hear a little bit more on our elders. Our deployment strategy for staff, we were contacted by the health authority, and they just made their own appointments and went one by one. We appreciated that the health authority was very aware of not vaccinating during shift time. So they did ask each employee when they were scheduled, and they confirmed, you're not supposed to be going to get vaccinated during work hours. We had maybe, out of 240 people, we had 158 vaccinated as of last week for our staff numbers, which we're pretty pleased with. We have about 190 on payroll. and the decline came mostly from the staff. The elders, we had 98% of our elders were vaccinated. Few people had declined. Their loved ones had declined, being the secondary decision makers. And one has since passed away and was very close. They weren't palliative yet, but were close to end of life. And so the family kind of took the approach of they'd rather that vaccine go to somebody that they knew was not close to passing, which we appreciate. That's not an easy decision for anybody to make. The staff seemed to be mostly around fear. It was fear of the vaccine. It came too quickly. It wasn't researched enough. It hasn't been studied. We don't want to be the guinea pigs. Lots of education, lots of frontline conversations, rounds, really simple infographics, everything we could to help understand why they're saying no, and try to make sure that they just had education behind where their decision was coming from. A pet peeve of ours was, well, we read an article on Facebook. So we can see some people laughing. We really needed to address that Facebook is not a reliable source, and let's try and figure out what would be reliable sources for you and share those and make them really easy to access. And then I've had a folder on our shared network drive that has more in-depth information if people really want to dive in, such as white papers, results from the actual clinical studies with numbers, and so they were well informed. My role was really a lot of organizing, collaborating, and just support. So lots of rounds on the day of vaccinations, and then lots of communication. You know, I'm thankful for technology that we're able to reach 250 people in a matter of moments, and that we were able to book all of our vaccines for staff over the Christmas holidays, which lots of us were very pleased. On Christmas Eve, we got our notice that we were coming. So that was awesome. And I think the only thing for us that we learned from was in our first round, we had 8 public health nurses come in to vaccinate our elders. We have 22 elders in the community, and it was a little too much. There was too many people for everybody living with dementia. It was much too stimulating. So we would have reduced that, or we would have split the team in a different way and had our staff, we did call in extra staff that day, but our staff do the 15-minute monitoring afterwards because our elders are familiar with them, and therefore they're not getting the responsive behaviors or the fear. We didn't want to scare anybody. We wanted it to be a really successful rollout. It was difficult at times when the questions were, well, what's COVID? And all of a sudden our elders for the first time were kind of recognizing, well, what do you mean I'm getting this shot for that? And how did you handle that when you had 4 minutes to move to the next person? And having the extra staff on hand was really important to being able to reassure that elder of what's going on and what it's for, and make sure we could answer those questions. So all in all, we're just excited to get our second shot, but very thankful our health authority has handled things really well for us here all the way on the island of the West Coast, and we're pleased for that partnership.
I have a question for you, Erin. With respect to the physicians that work with you, were they all vaccinated as well?
They were, but they were vaccinated separately from us. So many of our physicians are contracted. So we have a medical health director, but they also work in other facilities. And our medical director is the chair of our geological area as well, or geographical area. So they were able to get vaccinated again at the public health clinic, but recognized as a vulnerable population being in long-term care.
Did you know exactly what the rate of refusals is amongst your staff?
That's been a really difficult stat for us to get. We have asked staff that are comfortable to come forward and let us know that they've been vaccinated, but I know not everybody is. When the vaccine rollout first started, we had heard a lot of rumblings that people were really not going to get it. The results and the statistics showed us that the majority did. So I think there's a little bit of hopping on the bandwagon on refusing the vaccine, and I think some people actually carried some, I don't want to call it shame, because shame is obviously a very strong emotion, but some reservations about sharing the fact that they did decide to get vaccinated, and would they be potentially judged or negatively affected as a whole. We would like to see more statistics on exactly who was vaccinated, and the health authority has those numbers, but for privacy of information, personal information, we haven't actually seen the number of people who have refused it.
Great, thank you. Thank you very much. We'll come back to you, Erin, for questions a little later on. And I'll be moving over to Mary Boutet in Ottawa. So strategy, rollout, leadership.
Great. Thank you. Thank you very much. I'm really pleased to have the opportunity to share with everyone this afternoon and to learn from some of my colleagues. So here in Ottawa, I have the opportunity to work with a fairly large long-term care home. And the strategy here, we really have had a dual approach in terms of vaccination for staff and residents. So residents have been vaccinated here on site using the Pfizer and BioNTech vaccine, and that's a vaccine that our own nursing team has been able to administer here. That's a little bit different than the use of Moderna in many long-term care homes. There are some logistical challenges associated with that, but we've had excellent support from both our local acute care partners and public health to make that possible. And then for staff, the majority of our staff have been vaccinated off-site at a clinic run jointly by public health and one of our local hospitals. And we have also vaccinated some staff and essential caregivers here on-site. So today, similarly, we've got 96% of our residents have been vaccinated against COVID. And in terms of staff, we are probably at about 75% of staff currently who've received the vaccine, with another 5 to 7% who've consented but haven't yet been able to be vaccinated just due to vaccine availability locally. So in terms of the strategy that we've really taken here, we've leaned fairly heavily on some principles from behavioral science to try to encourage people to get vaccinated. So there are really three key areas that we focused on. One is making it easy as possible, knowing that we don't control all of the factors around vaccine clinics and administration, but how can we make this as easy as possible if that's going to be on-site or off-site? So that looks like multiple opportunities for people, again, considering when they're working, if they're being vaccinated off-site, how are they getting there in terms of transportation, parking, all of those logistics. The second strategy is really around making it normal. So again, when something is new, people have lots of questions, right, about what is this? And very few of us want to be on the bleeding edge of science. Most of us want to follow our peers, right? So how do we use strategies that really help demonstrate that this is the choice the majority of us are making? So we've really heavily leveraged communications, social media, the use of peer champions to have those conversations with people, and that really help demonstrate that this is a really normal, good thing to do. The other piece here is really focusing on making this the default option, so assuming right from the get-go that the majority of us are going to be vaccinated. One of the strategies that we use here that might be a little different from some places is we have an active vaccination opt-out program. And we use that not just for COVID, but we use that actually for influenza vaccination. This year we had over 91% of our staff get vaccinated for influenza. So we actually ask staff to make an active choice. We ask them to acknowledge the risks of not being vaccinated and to sign that they acknowledge that. And that's not meant to be punitive in any way. This really is a supportive conversation. We want to make sure that people have the information that they need to make an informed choice. The third principle around behavioral science we use is really about making this personal for people. So we see lots of statistics and scientific articles, and we don't always see ourselves reflected in that information. So again, how do we help people see themselves and how this lines up with their own values, the risk to themselves and their families, not just to residents and community, but really making that a personal choice for people. And importantly for us, particularly during COVID, one of the messages is about giving people back some control. So we've all lost a fair bit of control over the last 10 months in terms of the pandemic and the impact on work. And one of the lines that one of our staff members has been using here that's really resonated is give normal a chance, right? So how do we give people back some control over a really difficult situation? We have had a lot of education for people. So that is both, things that you're going to find in written format. For people who need a little more, we have a wonderful group of physicians who we work with who've been very supportive in having either one-on-one or small group conversations to answer questions, in addition to pharmacists, have also played a critical role in our education campaign. And then I would be doing a disservice if I didn't mention the importance of one-on-one conversations. So all of our staff talk to the person who they report to about their choice to be vaccinated. And again, that's not a punitive conversation. It really is meant to be supportive. So how do we help ensure that people have the opportunity to ask questions and to get the information that they need? We've had lots of really good discussions through that, everything from, I heard my colleague talk about Facebook, Reddit. Is Reddit a good source of information? We've had some people with really interesting questions around particular spiritual or religious objections that we've been able to then go back and get some resources that have helped them make informed decisions that they can be comfortable with. So that's been very helpful. And then I would just lastly like to say a lot of the work that we've done here has been based on some work that Jennifer Plant, who's our Director of Clinical Practice, she did her master's in quality and patient safety at U of T, and her master's thesis focused on improving vaccination rates for influenza in a small acute care hospital in Northern Ontario. And we've really leveraged her work and experience in that area for our strategy.
That's very interesting. It'll be interesting to see the reference. Jennifer Plant's work, it would be good for us to be able to read what she did and what was done in Northern Ontario. That's really interesting. Now I'll move over to Ms. Lucy Tremblay from Montreal. Over to you. Hello. So I work in a CUS, including one long-term care facility that was part of the pilot project. It's one of two that were identified in Quebec because they're large long-term care facilities. Now, I have to admit that we had to work very quickly because we learned on December 4th that we were part of the pilot project and we had to begin vaccinating on the 14th. So at the time of the pilot project, it was very difficult to move the Pfizer vaccine, and the information was not always consistent. From the outset, we were told we would get 975 doses, that we'd have to split in two. I won't get into the details, but at the end, we had 2,225 doses for the 305 residents, for the staff that are part of the various long-term care facilities in our catchment area, but also we had to expand to other workers, including workers in hospital settings. For the pilot project and for the rest of things, we always vaccinate residents on site. So the project is currently under the leadership of nursing care because initially we wanted to make sure that we would have professional practice that was well-resourced to provide the vaccine. And in the pilot project, we asked our executive nurses to be present and help adapt care protocols. We knew that there would be other type of vaccines down the road, And we knew that we would get a new group of nurses that would also be responsible for the immunization. So we needed to make sure that we could coordinate the care that would be provided. So it was really important for us to have a solid practice. I said that our first rollout happened on December 14th. When we went through our simulations, everything was rushed. We got our simulation box earlier than we thought. We had to train people really quickly. We had to explain how to manipulate dry ice. That's not something that people are very used to in long-term care facilities. So it's really the pharmacist in the long-term care facility that did the simulation. We included a freezer in the long-term care so that we could house the doses properly. And the pharmacists were also in charge of reconstituting the vaccine. Now, the staff at the long-term care facility are the ones that actually vaccinated the residents, and that happened quite quickly, over 3 days. The majority of residents accepted, as was the case for my predecessors, and it was done over 3 days. We also then moved on to staff, and staff were immunized over 7 days, and we vaccinated 2,225 people in total. And as us, you probably lived through the, will we have the 5 doses in the syringe? Will there be 6? So you have to adjust as you gather data. We had to make sure that we would control for contraindications, for underlying conditions, etc. So it was really important to work with residents beforehand. We had to make sure they had no symptoms, for instance, and also physical distancing. That required a lot of organization, something we're not really used to. So there were many variables, even to this day. I think that the pilot project should make us understand that these unknowns are here to stay. When will the vaccine come to our area? When will it be delivered? In the pilot project, we vaccinated everyone with Pfizer. Now we're vaccinating with both Pfizer and Moderna, as soon as they're available. So we have to manage the challenge of thawing and the time you need to structure the clinic. So that requires a lot of agility. Now, we've also tried to have as many workers on hand as possible, and people have shown up. I will say, when we surveyed our staff in December, 28.6% of people said that they would refuse. And then we had to delve in to see why would they refuse to get the vaccine. Often it was, well, the vaccine came too quickly. I want to make sure that I'll get a second dose. I have concerns with respect to the fact that I'm not sure how other people are reacting to it. And then when we looked at it more closely, only 6% were categorical about the refusal to get the vaccine. So all of our education campaigns have been structured to reassure people with respect to those specific concerns. As we used all the means we could, whether it's speaking directly with a manager, using social media. We tried to use social media in a good way that way. And we also tried to use champions. We produced short videos, and we went to get well-known personalities. Sophie Bowman is somebody who's really helped us a lot in that area and has been promoting vaccinating. So we have vaccinated almost 8,800 people, and I always think it's funny when, in terms of accountability, because we got 8,100 doses, but somehow we managed to extract 8,800 doses by being really careful. And so we've managed to immunize 8,800 people. Now, one last challenge is we needed to get more enthusiasm for the vaccine. But the vaccine is coming in dribs and drabs, and we know that only at the last second how many doses we'll have. So when we try and get buy-in from staff in Quebec, there's a very strict list of workers that are identified, the first being long-term care facility workers, those people that have direct contact with residents. The second category is those people that work in hospital settings and, again, that are in direct contact with patients. And we're beginning to look at immunizing community health workers in private clinics and family practices, but that's not started. And for the past 10 days, we've also been vaccinating retirement homes. So once again, those are vaccinated on site. And the staff go to the site, to the retirement home, for instance, and vaccinate all the retirement home. So that's what we did for the pilot project, and also that's what we've done after the pilot project. And we hope to turn to mass immunization, and when that starts, the frontline leadership will be in charge of it. Thank you very much, Lucy. I just have a quick question, maybe to all of you, in fact. I'll start with Erin. If there were something you'd like to change for the second dose, what would it be?
Certainly to go slower in the home because of our elders living with dementia. So we would have slowed down. It would have helped us monitor things a little bit better. It takes a little bit more time from public health, but it would have been more peaceful. And at the end of the day, it's their home, right? They don't live at our workplace. We work at their home. We did ask originally to do the vaccines ourselves and said we would be happy to train nurses, but it wasn't an option. We've now been asked if we have staff we want to train, and we said, yes, please, and would hope to do that, but we're waiting to hear a little bit more information. The other thing I might change, I did forget to mention that all of our essential visitors were also vaccinated along the same line of our staff. So not with our elders on site, but with our staff. I'd like to add designated visitors, if we can, who are not considered the definition of essential. Of course, we understand they are essential, but they're not defined as essential. So that would be another thing that we would prefer. People are nervous about the 42-day mark and potentially not getting the second dose in time. So there's a lot of risk management and reassurance to what happens. And the reality is we don't really know. So we're trying to plan for all options as best we can.
Great, thank you so much. And Mary?
I would echo a lot of what Erin shared. One of the things that we don't have a lot of advance notice, that we're running a clinic. It's often been 24, 48 hours if we're lucky. So that's really not a lot of time to get out a call, particularly for first vaccinations for people. So that would be one. I don't control that. But another that I would love permission for, so we're using here in Ottawa the Pfizer vaccine. You do have, once it's thawed, 5 days that it can sit in a fridge. I would love to have a few extra vials in the fridge to catch people who either aren't scheduled to work that day, or we've had a couple of residents for whom it's just not a good day to be vaccinated. And we had a couple of declinations from residents who just were experiencing some fairly significant behaviors, and it wasn't going to happen that day. So it would be really nice if we could have just a couple of extra vials when they're here and then draw them up and administer them within a couple of days after at a time that worked.
And Mary, a question. As far as essential caregivers, were they vaccinated at the same time as residents as well?
The same time as staff, so both off-site and on-site. So they have been included equally as part of that approach.
Great. And Lucy? In phase 2, what would you change? What would you improve? I share my colleagues' opinion. If we could know ahead of time so that we could get better organized. I was explaining to my family that it's as though you were organizing a wedding and you were told 2 days before how many guests you'd have. So in terms of planning, HR, and the sites, it's really difficult. And people have to work long hours just to come up with appointments. And so if we could know ahead of time, that would really help us. If I had one pie in the sky dream, would be to have more stability in the doses, because at the moment, although we can split the vials, I have the same problem as Mary, where sometimes residents, how shall I say, that maybe they weren't ready that day, so how can I administer the vaccine later on? And given that vaccinations began on December 14th, we've had admissions since. So we have a backlog of people that we need to vaccinate as well. And in our catchment area, there are long-term care facilities that are smaller. So before we have a critical mass of people to even have 5, 6 doses, we'll need a certain amount of time before we have those 5, 6 people that we can administer the dose to. So I think we need to look at a regional approach. So vaccinate when people are in hospital before they're moved to long-term care facilities. Now, some people are admitted right from their home to the long-term care facility, and those have to be handled as well. Lucy, did physicians get a vaccine in your case? Yes. Actually, all the physicians that work in long-term care facilities have received the vaccine. It's not necessarily the case for physicians that work in retirement homes, because often they only work with 1 or 2 residents, and currently we're told only to vaccinate those individuals that look after a long-term care facility resident, or physicians that deal with long-term care facilities. So yes, physicians have generally been vaccinated. Same thing for essential caregivers. There was a criteria. There was a age criterion, for instance. There had to be an age, the number of times they visit. They had to visit at least 3 times a week. They had to be at least 60 years of age or older, just so we could have some sort of triage criteria. And, you know, for those individuals that didn't come visit because they were afraid of contaminating their loved one, they aren't eligible because they haven't been visiting for 9, 10 months. So I think that that's something we have to look at. There are some people that stayed away out of fear, and they should be eligible. Mary, are caregivers vaccinated based on a certain criterion, for instance, over 70 years of age, or they have to come a certain number of times, or was there no criteria at all?
So in Ontario, all residents have the right to designate 2 essential caregivers. And these persons have 2, yes. And these persons have the right to be present in the home, even during an outbreak. So the vaccine has been made available to those registered designated caregivers. They do have to demonstrate proof from the long-term care home that they are a designated caregiver before receiving access to the vaccine. But that could be somebody who's 30 and very healthy with no comorbidities, or that could be an 88-year-old spouse with significant comorbidities. And the thinking really is about protecting the long-term care home as a whole community. So making sure that anybody who comes into the home has been vaccinated. That's the thinking and rationale.
Thank you. And what about you, Erin? Were there criteria to vaccinate caregivers?
No, as long as you were an essential caregiver, there was no age limit, there was no limitations whatsoever. So we're much smaller. I'm understanding and listening to my colleagues, we're much smaller than the other homes on our panel today, and that's given us perhaps some flexibility to vaccinate our whole community. It's such a small world, though. My grandfather lives at Pearlie, and my grandmother's an essential visitor, and they both received their second dose, I think last week, Mary, was it? So as a family member, I'm very thankful for the fact that they were able to both be vaccinated and that much safer.
Absolutely. And Lucy, in your case, I think pharmacists played an important role in preparing the vaccine, and that must have helped you in the whole process. Now, in other settings, were pharmacists involved? Yes, actually, pharmacists were present almost everywhere to prepare the vaccine. It has to be done in an environment where we could maximize the potential of getting as many doses as we could out of the vial. And it also allowed us to improve flow, so to have a more fluid process. And that's why pharmacists were put to very good use in managing the vaccine, in conserving it, in follow-up, and essentially that's for the Pfizer vaccine, because the Moderna vaccine is a lot easier to handle. What about you, Mary? Are pharmacists involved?
Yes. So here, pharmacy is a third-party contracted service in most of Ontario. But we are very fortunate that the pharmacy provider we work with embeds several clinical pharmacists within our home, within the team, and they've been very involved. I know one of the clinics that we ran for staff and caregivers was a Saturday clinic, and the clinical pharmacist was in answering questions one-on-one with staff who had questions about the vaccine itself or potential contraindications. Some of the early information that had come out around groups that had not been involved in the study trials for vaccine, there were some interesting disclaimers that were made that caused a lot of questions for people. So if I'm breastfeeding, is it safe for me to get this vaccine? A number of women who are pregnant who had wanted to have a conversation with somebody about that. So he's been fantastic. He also called any family who declined on behalf of their resident. If they had any questions, he called them one-on-one to have a conversation about the vaccine itself and its safety.
Great. What about you, Erin? Were pharmacists involved in your case?
Not nearly at the same level. Like Ontario, all of our pharmacists are also contracted, and we did use them certainly for education. They had put out some, how to have a small huddle with your team and discussion points, which we appreciated. But we really collected it from all resources. They would be available if we had questions, but mostly even we had a couple elders have a reaction to the first vaccine that went directly to the physician. It didn't go through the pharmacist first. And actually for one person, it was decided that we wouldn't do a second dose for them.
Great. Well, I think this is really interesting. We have a question period now that's been planned. Tanya, do we have any questions online? At the very end, I'll summarize, because I find that it's really interesting what we've heard about the various ways that we've proceeded. So over to you, Tanya, for the questions. Great. Thank you so much. Yes, we've received a lot of questions, so I'll try and focus on the main ones. Between Erin, Mary, and Lucy, thank you for answering them as they came to. So there's one conversation from the very beginning. What are your recommendations for staff who have autoimmune disorders? Do you recommend that they get the vaccine, yes or no? I think Mary is wanting to...
Yeah, this is actually a question we had from quite a number of staff. So the consent form that our province has put together for the vaccine, that is a flag that's there. Very early, in the very first days, any staff member who had an autoimmune disorder, public health was using that as an automatic screen out and wouldn't let individuals book a vaccine appointment if that was the case. Since that time, the direction has changed, and it's now recommended you have a conversation with your physician about your particular circumstances. The reality is, more often than not, this is exactly the population who would be at very high risk for complications from COVID. And very often would be exactly the population who you would really want to encourage to be vaccinated. The reason why that group was singled out early on is that persons with immune deficiencies were not part of the study trial groups. And so you couldn't say definitively, without question that there wouldn't be an issue. They're usually excluded, though, from vaccine trials because they don't mount the same immune response. And so they're not good as a study group. It's not because it's not safe for them. So I know we've had several staff with various immune disorders make the decision to be vaccinated. And most of the physicians who we are working with are recommending vaccination for their immune-compromised patients. The profile, the only groups that I've really heard physicians recommend against getting vaccinated are those for whom they would not recommend the flu vaccine or another type of vaccine. So that tends to be the same general profile or recommendation. If you're allergic to one of the components in the vaccine itself, if you've suffered an anaphylactic reaction to a previous vaccine, etc., those tend to be the groups that they're focused on.
Thank you. I'll ask you separate questions so that we can cover as many of them as possible. So, Ms. Tremblay, the next question is for you. How will you ensure new residents are vaccinated? Because you've already gone through a first wave of immunization for those that were already in long-term care facilities. What are you going to do for new admissions? We're working currently on vaccinating people in hospitals before they're transferred to long-term care. But for those people that come to long-term care straight from their homes, we're trying to see what type of strategy we could implement to make sure that we have a critical mass, especially in those small long-term care facilities, so that they can get the vaccine in short order. So that has not yet been determined. Thank you. Erin, next question to you, because I saw that you've been putting some answers in the chat box. So have you planned extra staff for the second dose, just in case there are reactions amongst the residents?
It's hard because we don't know when the second dose is coming, but yes, our intention would be, we understand that perhaps people will have a stronger reaction or a stronger effect from it, and we did have a couple people, maybe 5 or 6 staff-wise, that had more than just a sore arm the next day that kept them from work. So we will have some supernumerary staff on site. Of course, the team's never reluctant when they've got extra people around, so it's always helpful. But even if it just eases anxieties, we can always use an extra hand. For the elders, it was really important, given that everybody here has dementia, that we have a familiar face, especially behind a mask. We'll have as many casuals as we can squeeze in and afford to be able to be those extra support pieces, and to reassure the staff when they need to go take breaks and we're ended with limited staff on the floor, that there's some help available.
Great. Mary, next question is for you. What type of reactions have you seen with people that had the virus and then got the vaccine? Did you notice different reactions in staff or residents?
Yeah, so in terms of staff, we have had some staff who've tested positive for COVID who have chosen to be vaccinated, which is a recommended group. We haven't noted a different pattern with that group explicitly. I don't know if we've really looked for it either. And in terms of residents, I don't think we've seen any other reactions amongst that group. We had here, I think somewhere in the neighborhood of 25, 26 residents who have tested positive for COVID last spring. And amongst those who have been vaccinated now, we're not really seeing anything that's that different. The most common side effects from the vaccine, sore arm is the first. And then with the second dose, we did see, particularly amongst staff, a little more, low-grade fever, body aches, just being really tired. Nothing significant, but we did see a small uptick in our sick calls. We did staff up for our second dose for residents, but I think as well, because older adults don't mount the same immune response to a vaccine, it really hasn't been anything that's been that difficult to deal with.
Thank you. Ms. Tremblay, how will you manage those people that refuse the vaccine and local policy? Will there be different policies for those people that refuse the vaccine, especially for those people that are in charge of providing care in long-term care facilities? So, well, that is more of a legal question, but there's no hard line against people that have refused the vaccine. We're not, on a legal basis, able to exclude them from providing care. So our goal is really to convince them that it's the right thing to do. We want to provide it to them as quickly as possible, and people can change their mind. Somebody may refuse, they refused early December, and now they may want to make an appointment, and of course we'll let them, and that's what we're hoping for. So we're more in a supportive role, if you will. We also started a campaign, much like what's done elsewhere. There's a pin that you can put on your lanyard to show that you have received the vaccine. There's the Facebook campaign. I think that this whole FOMO, fear of missing out, is really important, and that's what we're focusing on, to try and get as many people as we can. Now, with respect to the survey that we are currently administering, we're noticing that the number of staff that are getting the vaccine is increasing. So people seem to have been reassured by what we've said. What we're noticing as well is that more people are informed, the more they'll agree to get the shot. So we have to also be role models. We have to try and convince them regardless of their role. Thank you. And one last question for Erin. With what's been provided to caregivers in terms of vaccines, has it changed your point of view of the role that essential caregivers provide? Was it always the case? Did you see your perspective of their role evolve?
Certainly, as soon as our elders were vaccinated and the risk of a number of people passing away and an outbreak was greatly reduced, yes, we felt much more comfortable in bringing in more individuals through our door. It's a hard one. That's been the hardest part about these 11 months, has been restricting families. I don't think any of us expected to be in a position where we were telling a crying wife she couldn't see her husband, and it's been absolutely heartbreaking. The more we can safely open our doors, and I'd like to adopt a little bit of what Ontario has done. We've been very restrictive in British Columbia about visitors, and there's large, strong advocacy groups. The more we can open, the better for everybody, especially with everybody in whatever stage of dementia they're in. They don't know why their family isn't coming most of the time, so they're just confused, and it's pretty sad. So it wasn't so much the essential visitors being vaccinated that made a difference, it was the elders receiving the vaccination. One thing I wanted to mention too is a big reluctance from staff was if it doesn't stop transmission, what's the point? They would be much more likely to do it for the elders than they are to do it for themselves. So that's something we look forward to hopefully seeing in other vaccines, or then outlining what an ill staff member's effect on the healthcare system as a whole has on our society and our community. So that I just wanted to make sure I snuck that part in here. It was a big deal for us.
Thank you. And now over to Dr. Ricard so he can summarize the conversation. So in summary, as we've seen in media, we're trying to build a plane as we're flying it. That's more or less what we've been through with the delays, the various ways of doing things, various vaccines, and in a scenario where you have to be physically distant from people. So the key words I would keep in mind is what you said regarding flexibility, the schedule, the location, and another thing, it seems that it's when it's the staff that residents know that you have the greatest success. And I think it's really important as well to counter misinformation with information. And I thought it was really interesting, Mary, what you said, your opting out method. So you have to consent to sign something that explains what the risk is of not getting the vaccine. I think that's really interesting and important. And compared to Quebec, I feel that your access to vaccines for caregivers is much more flexible. I think that in Quebec we were far too restrictive compared to what you've done in BC and Ontario. So I thought it was really interesting to see how you've done things, 3 different ways of doing things, but really informative. Thank you. Yes, indeed. Thank you to everyone. Thank you for sharing your experiences with us. And as you can see, there were a lot of questions in the chat box. So it's a hot topic. It's of interest to many people. And we have lots of hope for the future, that's for sure. So to conclude this webinar, I just have a few more slides to show you. So some of you asked if you could have access to the resources that we talked about today. And there is on our website a lot of resources that have to do with vaccines and vaccine rollout in long-term care, including those that Mary Boutet mentioned. So please go to our website and you'll find a number of resources that have already been created by many organizations throughout Canada to deal with vaccinations. And also the next steps for this program, our long-term care program, we are still open to working with you wherever you are in Canada. So we'd ask you to identify your patient partners and to fill out the self-assessment tool, and also to register for the long-term care community that we've created across Canada. This will give you access to coaching for quality improvement, change management, and it'll give you access to our webinars and our LTC huddles, as well as potential funding of up to $10,000 to help you with your quality improvement initiatives, including the rollout of the vaccine. So when we developed our program last July, obviously the vaccine was far into the future. We were hoping it would be closer, but now that it's here, we're here to support you with your immunization campaigns. And to this date, as you can see, we've created quite a community of many centers across Canada. We have 405 institutions that are part of the program, and we're always there to support even more applications. Our next huddle will be on February 18th at 2 p.m. Eastern Time. We'll hear Dr. Louise Clément, who's the Executive Director, Clinical Partnerships and Education Accreditation at the Health Standards Ontario, HSO. And she'll discuss the importance of the self-assessment tool to continuously improve quality. And finally, our last webinar for this first series will be with André Picard, who's a renowned journalist, works for the Globe and Mail, and we'll be discussing his recent book, Neglected No More. So that will be an interesting conversation then with André Picard. As always, if you have any questions, please don't hesitate to reach out. You can reach us through our website or our email address. Thanks again. Thanks for being part of this webinar today.